Okay, thank you so much, Patty. Let's have a quick discussion, and because we are under pressure of time, I'm going to open the floor for discussion straight away, and people can ask questions. While you raise your hand, I would like you to please answer my question.
Okay. So the question was primarily about health promotion, right? And I think you saw the bias in my advocacy of the public health pyramid, which is that while education is certainly valuable and never harmful, it probably has the lowest impact on population health outcomes. So it was actually fairly intentional that I exposed my bias, and you discovered it.
Yesterday, you mentioned something about causation, that it's important for us to have the evidence to move things forward. We need to be able to establish causality. But now I want to ask Patty the same question about causality. The kind of evidence the kind of research that you're asking for, which is real-world research, is often criticized for not being robust in terms of establishing causality. Then what?
Well, that's what I'm challenging. So I think we need to learn how to do better, how to bring that research into the field. And that's implementation research, or you call it integration science, or you call it program science. And I think the funders had to understand that they're going to be putting a lot of money on research, showing causality, and we have lots of examples. But then when we try to put that in the real world, it doesn't work. And it doesn't work because we have not analyzed all the other components of the systems. So I really think that this is the time in which we have to understand that unless we do it right, we're not going to go through that bridge from research to policy. So we need both. I'm not saying that we need one or the other. I think we need both if we really want to use the best of every dollar that every funder is putting in basic research or in the other research. I'm an epidemiologist, but I learned that, and actually my basis is quantitative, but now I know very much that I not only need to count, but I need to understand what people are thinking and why they will do something or not. I was joking the other day saying, like, now I understand why there are so many disciplines that study humans, right? Psychology, anthropology, sociology, because we're so complicated and so complex that when you want to introduce something in a system with humans, almost everything that could happen will happen against the success. So you need to understand how to make it better.
Okay, questions?
Thanks. Yeah, I think this is an interesting panel because we have, someone earlier on said we need politicians in the room, and that's always a sensitive point for the National Academies and this sort of thing. But we actually have kind of a politician in the room. Kind of another politician in the room, actually. Jay, you were pretty high up in the New York City Public Health Department, and you tried to and were successful in pushing through some pretty radical public health legislation that dealt with NCDs. Some of it worked, some of it didn't. And we also have funders in the room, and a funder and a foundation director who probably goes to politicians to ask for funds for NCDs and infectious disease. So how do we get this message, this complex message, we've heard a lot about it, into the right simple language that a politician, a policymaker will understand and therefore support this agenda? What's the trick? Can you make a comment on that?
Great, and this actually this gets to the question you asked as well too, like where I think about communication. I've struggled throughout my career with not so much communicating to the public, but communicating to the public's representatives, which are the parliamentarians or council members, depending on what level you have. And they are, for good or bad, a representation of what the general population thinks. And this is where I mentioned a little bit about the issue about causation, is that even though that there are ways in which, if we use science to communicate the direct linkages between the factor that we want to alter and the outcome, or the intervention that we want to make and the beneficial outcome, that it can help, I think, with the communication. because that inability to explain the direct causal link and to simply talk about correlation has been very challenging. When you're referencing whether it's related to, control of sugar-sweetened beverages or any of these other factors. At least in the U.S. political context, it comes across as, and actually globally, it comes across as nanny state policy. But if you have a factor that you can target, it's looked as, oh, we found an enemy and we're going to fight that enemy. And so that's the reason it's informing at least my thinking and my experience working with elected officials.
So far, what's your experience with the AU?
The dilemma in the AU is the fact that, you have a deliberative body that's been established, but doesn't have still full institutional functioning ability yet. And so within the AU, it's actually remarkably easy to get, say declarations or approval on thing, but the execution doesn't match that. And that's where the institutional functioning is a gap. It's actually a kind of an unusual body in that it's actually quite easy within the AU, we found, to get agreement on something, but that's partially because the consequences, they don't feel the consequences. The commitments are supposed to be binding, but nobody really binds people to them.
Well, I think the message to the politician has to be that we do not have the luxury of dealing with these sequentially. Not in a country like India, where both of them are very much there. One has not gone out of the door, the other has already entered. So you have to deal with them simultaneously. Therefore, you have to build health systems which can deal with both of them simultaneously. Because both of them kill people, both of them cause a fair amount of morbidity and a lot of economic damage. So you have to build systems that can actually competently deal with that. But if I may just take up the issue of causality, if I may? Sure. Okay. See, the problem, of course, is that causality cannot always be seen in a linear fashion. Of course, for non-communicable disease, you have the Bradford-Hill criteria and all that. But on some complex issues, you can look at construct validation. And if you have reasonable evidence of association of risk, then the evidence on intervention can follow later, and you can apply the precautionary principle for external agents, whether it is second-hand tobacco smoke. You ban it, and then you see what the change is. Or even sugar-sweetened beverages, if there is reasonable evidence of epidemiological association of intake with adverse health effects, then because it is something that is not naturally introduced, you can certainly apply the precautionary principle. But you'll have to make a case for that. But the problem, of course, is that in most of these cases, it will be heavily contested by the industry, and therefore the common sense logic necessarily doesn't always register.
I'm going to use that. Communication. Yes.
So one of the things that I learned is that not all the policymakers or all the politicians are made the same by God, okay? And so you need to have different ways of presenting things. So number one, data may help, okay? But it has to be given in a simple way. And if you talk about associations or relations, I mean, you have to be very, very clear. So that's one, data. The second, some are just interested on how much it will cost and how much they will save. So it is so effective to work with an economist and have cost effectiveness analysis. And that's why, I was able to convince first the Ministry of Production, then the Ministry of Finance, and finally the President to fight with me and being able to start all the process of labeling processing food in Peru, which starts in June 17th. Now, after all the things that we have done. But it was a matter of talking in the same language. And the same language for all of them was how much you are going to save, because how many people are having chronic disease, dialysis, and all the things. So cost effectiveness is a second thing. The third thing is human testimonies or stories, okay? So some of them will be moved by those kind of issues, and sometimes we don't use that. Sometimes it may feel complicated but those are the moving things that can really change their minds, okay? And the fourth thing is you cannot do it alone. You have to work with other partners. And these other partners, and which were really helpful for me, for example, pushing coverage of HPV vaccination, were the community, okay? So mothers that were convinced that this was important, although in the Congress, they were having these ideas that vaccination was going to be against everything. So they start listening about stories of cervical cancer, about how important it was, etc. So I had all the congresswomen wearing the t-shirt that says, I have been vaccinated by HPV, and then we start pushing up. So I think we have to do everything at the same time, and because they are different ways. It's very intensive.
Does that answer your?
That's fantastic.
All right. Okay, let's just give you.
But just I guess an added point that I found is that Peter and I were talking earlier about this. I found, in addition to, it's really about generating public outrage that always changes things. But I think the dilemma we have with chronic disease, or at least is that people are stuck in two areas. This is why I like the causation. They're stuck in genetic fatalism. I was born that way. Or they're stuck in lifestyle choices. Oh, those people are fat because they can't control themselves. If you make it seem like something is being done to them out of their control, they will demand that government do something to push back, which is why infectious diseases are easy. It's like, I can't control the viruses that are spreading. I need government to protect me. And so that's a little bit why I'm sort of obsessive about this causation issue.
But I think, so this is giving us an advantage, and that's what I said, that we have to give a positive message when I was talking about, the fact that, people see infectious diseases as something that you can do that's why they love antibiotics, and that's why they go to the pharmacies to buy antibiotics, because antibiotics almost cure everything, right? But with chronic diseases, you're right. I was born like that, or I cannot change my lifestyle at all. So having this association, I think we have to take it positive. Now that we know that there is an association, maybe we can do something, okay? So there are vaccines that, when you tell people that there is a vaccine that can avoid them to have cervical cancer, and you tell them that this is because technology is allowing us to understand better things, because people love technology, even in rural areas, their eyes will bright. And then, and I agree completely with you, that public push or that public outreach will help, because politicians are looking for votes and for people that will see them, that they have done something so they can be reelected. So you can use that opportunity. So I think this association should be a plus for non-communicable diseases and for the interest on that. And I think we have to use it.
Just on the issue of choice and nanny state, this is, of course, always pushed by the industry, saying that it's a matter of individual choice. But choice can be either conscious, conditioned, or constrained. Conscious on the basis of correct information or incorrect information. And that's where health literacy comes in. Conditioned by aggressive marketing and peer pressure. So that's where some of the interventions need to come in as well. Like controlling tobacco industry, alcohol, and so on and so forth. Third, of course, is constrained. I may recognize that I must have fruit and vegetables 5 times a day. But at the same time, I cannot afford it. So you have to make the healthier choice, the more easy choice, and the affordable choice. So unless all those conditions are in play, choice is actually a euphemism for.
Yes, go ahead.
Wow, everything you said. This is all really fantastic. Before I make the point I was going to make, I just want to pick up on the point you made, Patty, around the understanding the stakeholder, and just reflect on the fact that sometimes we neglect the tools we already have. In public health, we have this kind of stakeholder analysis. So we actually have a way of thinking about, understanding how we engage around the level of influence and the level of interest and level of influence, and knowing what box they fit in, because the approach of somebody who's got high influence, high interest is going to be different from somebody who is, et cetera. So this is not the science, but actually in the way that we do engage in transdisciplinary research, we often neglect the tools that we actually already have in our pockets. First thing. And then just four very quick points I wanted to make. Thank you really for putting up that public health triangle. I think it would be really interesting to map everything that is being said onto that triangle to see that we are, because technically we should be following that triangle in terms of our visionary statements. And I kind of get the feeling that it was actually, so it'd be great to see that. In looking at the arrows on either side, so the increasing population impact and increasing individual effort, it struck me that also within population increasing impact was increasing complexity. And I just wanted to highlight that, and this is partly due to our disease. The second point was, and this picks up on the point you just made around thinking about making the healthy choice. I think for me, what was missing from that is that intersectoral action, because I think it was really crucial what you put there around the healthcare and quality of healthcare. But if we're going to make the healthy choice easy choices, we have to be thinking intersectoral action in that space. The third point was around surveillance, and this is a point I made at the beginning of the workshop, of us thinking about moving surveillance beyond just disease. And we heard earlier about how you have cancer registries that don't have, we don't have any of the socioeconomic information. So how can we start thinking about surveillance and using some of these technological tools that exist to pull in that socioeconomic, which addresses that fundamental base of the pyramid. For example, why is it easier for us to think microbiome than it is for us to think exposome? When we're drawn to microbiome, but actually exposome is something that was basic. We know impacts on health. Can we think more innovatively about surveillance approaches to both disease and the exposome? And lastly, because you mentioned precision medicine, I'd like to make a pitch for precision public health, because there is an approach, because we often think about precision in the context of individual, but actually I think there is a lot we haven't pushed in terms of the boundaries of thinking about public health and the potential for those precision tools to actually help us in thinking more population scale and more innovatively. And so just pushing for that precision public health. Thank you.
Thank you. Comments? Questions? I'm not shy to close the session, but I'm just kind of wanting to take advantage of the wisdom in the room to make sure that we can engage the speakers and hear your thoughts.
Yeah, I just want to make one comment. It's about the exposomes and microbiomes. Okay, we have some efforts trying to measure these exposomes. We call it determinants of health, okay? And so we are measuring them. It's that when you measure microbiomes and you find something, then you start thinking about technology, and then you start thinking about something that could be sold in the market. And I think that's why these kind of things that are more techy and move around. Well, when we are talking about exposomes, so social determinants of health, okay, what we're talking about is about very complex issues of our society that cannot be even moved by governments themselves. So, and this is something that we need to say loud, because, I mean, it's not just talking about assistance from one country to the other, okay, because that is not going to be sustainable, but we're talking about things that are much more difficult and much more complex to improve, okay? And within this whole system, corruption is involved also. So, and I go back to this because I think we need, and I appreciate your comment. So sometimes we have been doing the things that are much simpler, although microbiomes sound very complicated, but they have a way to go on, right? Changing social determinants, I think we need to keep studying, but we need to think about that at the end. Probably instead of spending so much money on tuberculosis, on HIV, etc., we need to see how are we going to erase poverty, because once you erase poverty, probably most of the things will be erased. And very easy to say.
Which is the argument for bringing in the surveillance of disease and the determinants, because actually I think we keep them separately. But
well, we're putting them together.
Yeah. So, yes. I would like you to start thinking, Patty, Srinath, and Jade, start thinking about who's supposed to do what. I would like to get to that. But before we do that, let's hear a couple more
I
questions.
want to make a comment about this last discussion, because I think that this is a fundamental issue that we have as a species. We're kind of stupid, you know, and we all suffer from this. We love the technological fix. You said that. It's so true. And vaccines are a great thing. Just a quick jab and you're cured for life of whatever horrific disease, or an antibiotic. And I think the microbiome is cool because it's actually incredibly complicated. We don't really know what the heck's going on. We heard that from the talks, but it's cool in its technology because it's a computer screen with lots of yellow, green, and red blips that you don't really understand, but the scientist does, and it actually answers everything about your life. It's almost like a crystal ball, you know. It takes us right back to our beliefs, you know, our species that our communities that have beliefs in the village elders that say, oh, they hold up the entrails and say, yeah, it's going to rain tomorrow. In this case, it's a really exciting technological thing. So what you said, I've never heard the word exposome. I think it's great. I've never heard that. But it's certainly far more exciting. And if I was to tweet out two things, you could see which would get retweeted most. Hey, have you heard of the exposome? That would. Have you heard of social determinants of health? That's the problem. This stuff is not cool enough. We've got to make it cool.
Bridget, just hold on a second.
Sorry.
Actually, the word exposome was coined in 2005 by Christopher Wilde, and as distinct from the genome. And that doesn't include only the social determinants, but also the environmental determinants, all the other exposures, including the toxic exposures, as well as the body's reaction. The whole idea here, I mean, the whole area of epigenetics now also is part of that body's response. Therefore, I think the whole idea is that the previous genetic determinism now has to be looked at very differently. And there are a number of things which are potentially modifiable in all of this.
Bridget?
I wanted to add to that conversation because I think the reasons we get excited about the microbiome and maybe not quite as excited and energized about the exposome is partly has to do with like what's cool, what's not cool, what's interesting, what's not interesting. But I think a lot of it has to do with what's safe and what's comfortable. And for people in these rooms to have to be talking about poverty and fairness and equity and the have-nots, they tend to be communities of haves. And when you talk about feeling like you might have something to lose and who feels like they have something to lose, it's uncomfortable. And there are some disciplines that are trained to sit with that discomfort. Most of those disciplines are in the social sciences. We spend less time on that kind of self-reflection and that kind of how to grapple with that personal discomfort that starts to come in. And maybe there's some personal discomfort when you're talking about, you know, collecting, you know, samples for microbiomes. But I think it's profoundly uncomfortable and it feels risky to embrace those things as things that we have to actually face and do something about. So it's not just cool and uncool.
Yeah, but again, we have a situation where, on the one hand, we want the quick fix of technology, but on the other hand, we want to empower people to look after their own health. So how do we play the two against each other, between the microbiome and the exposome?
I'm not sure that we actually have agreement amongst ourselves that we do want to give up that power. Right, we say it a lot, but do we really want to give up that power? Do we really want that transfer of power to happen?
Now, you should have mentioned this yesterday. We've had the whole day and a half, and now you talk about this. Now the elephant has just come out.
Yeah, I mean, I mean, again, I guess yeah, I mean, I guess sort of in our defense, I mean, I think that we in the public health sphere try as much as possible to avoid, you know, messages that appear to be overtly political. Deep down, we should all know and understand that all of science is determined by, philosophies and ages and, and things. But we try to do it. And so it's not so much that we don't want to talk about that discomfort, but we find it to be, when we stick as a technocrat, we can find a way to thread that needle a little bit more. I mean, for me personally, I actually have my strategy on public health when talking to legislators and things is almost never to talk about the benevolent benefits of health interventions. I like to talk about security, opportunity, and justice. Security, something's coming to get you. Opportunity, you're going to make a lot of money off of this, or you're going to save a lot of money. And justice, if they happen to be somebody that believes strongly in addressing inequity, because it's going to get them votes and things like that. So, at least for me personally, I don't think it's because I don't like the discomfort. It's like I would rather frame it in a way that I could appeal to people on either spectrum, those who are genetic fatalists and think, the world is structured a certain way versus those who are like, oh, it's all individuals making bad decisions.
I thought there was going to be an overwhelming response to that statement. I'm surprised everyone kind of went quiet. Am I the only one who's feeling discomfort? Okay. I would.
We should. You're not sure that we are, but
Yes.
we should.
Yes.
Okay, so I agree with her. So I think she's bringing a good point. The problem is that also there are conflicts of interest between providers and what they are offering, right? And to let the communities start taking also the power. And plus, there is this paternalistic feeling for the communities, and I think those are the kind of things that we need to change. I don't know if it will be changed in one generation, and that's why I started talking about training, because we have to create a different and undo things that we have been doing, because we need to create different type of providers and people. So we should not be uncomfortable. We should involve people in their own health. And maybe instead of solving the problem, I have nothing against understanding. I would like to know what is my microbiota. I would like to see myself in the mirror and find out what colors I have. But then I will go and ask the spirit of my grandmother and ask her what vegetables I need to eat, okay? So, because that's kind of what we are, instead of eating something synthetic, you know what I mean? So it's kind of, I think we need science, but we need also to kind of like go back on the good things that we used to do.
Well, in response to what Jay said, how you communicate to a policymaker depends particularly on the setting as well as what you expect the policymaker's behavior to be. But it's very true that a policymaker, when acting in an individual capacity, is more likely to be bothered about the kind of issues that you have raised in the context of national action or limited regional action. But when you herd them into a room in the United Nations, they would all like to appear very benevolent. So you sign up to the SDGs and so on. So you have to move them in that direction, get them to commit to some things, and when they come back to the country, then push that agenda forward.
Yeah.
Rachel, you've got the mic?
I do, but I'm not ready.
Oh, you're not ready? You're still processing? That's fine.
Just a reflection on both of your comments, and share something I learned fairly recently borrowed from political sciences, is the notion of the Overton window. And I don't know if there are any political scientists in the room. Overton window. So it is essentially, if you imagine a kind of spectrum going up and down, a scale, in thinking about the kinds of things that we want to achieve, there are different levels of going. If policy is in the middle and it goes from the bottom from unthinkable to radical to acceptable to plausible to policy. When we, as public health particularly, think about action, we basically want to go from unthinkable to policy. That's not practical. And so when we think about impact, sometimes, because we're trained to our funding grants, so impact is our policy relevance. But actually, if we're starting from an unthinkable idea, impact is moving it to acceptable in one generation. or something, because what you just said about generational timeframes reminded me of that. And sometimes it is worth us reflecting on how the state of play of what we're trying to do is different which is maybe the difference between the microbiome and the exposome. So maybe the microbiome is acceptable and we're trying to move into policy, whereas the exposome is unthinkable or radical and we're trying to move it up. So the time frames are different, and it's just, I found it very helpful to reflect on my interventions and what I'm thinking about and where that sits in current society, to think about what is actually feasible.
Who should do what? Yeah, Rachel. Yeah.
So it's maybe a little bit of a jumble, but I'll just try. I really, really am glad that you brought that up, Bridget. I mean, we are intellectual elite here, and it's so easy for us to pull back into our comfort zones of our disciplinary acceptability and the skills we've been trained to apply and so on. And I really appreciate, Patty, that you just said power. I think that was the first time that word has come up. And it's really important to put a lot of this into a power framework, and then think, if we're going to be thinking about microbiome, for instance, where do people have power? I talked a little bit on the break with trying to connect what happened, what we discussed yesterday, what we heard, most of which I didn't understand in the afternoon, but I tried, with what we talked about today. And maybe where people have power in that connection of the microbiome to policy or what they experience is their diet, right? Or getting what Jay has been banging on about today, better communication about the mechanisms. But those words aren't going to work. But something that gives people something to grab onto and a little power in that discussion about microbiome. And the same applies to these others, whether it's exposome or genome. And so I guess it's rather jumbled, but I really think maybe NCDs provide us with an opportunity to unpack those things in ways that we haven't been doing in the global health world, because we have so many needs and they're not being addressed in the standard ways. So I think we have to sort of flip things.
So it's not really jumbled what you're saying. Yesterday, when Rob was talking, he spoke about the fact that there were 4 things. You cannot do food alone. When you're dealing with microbiome, you need to do food or diet, you need to do immunology, you need to do microbiology, you need to do antibiotics. That, for me, is complex. But he also said that, what they would really like to do is to focus on how to manipulate the microbiome. And the alternative would have been that you can empower the person to change their diet in order to modify their microbiome, but that'll take 6 to 12 months to do. And on several occasions, he also mentioned how, whether you're you're spending a lot of time outside or indoor, that determines your microbiome. In a way, there's a certain kind of healthy microbiome that we will all like to achieve, but it's difficult to rely on efforts that empower the person to manage their microbiome and improve their microbiome. It would be a lot easier to manipulate the microbiome by giving you something, technological or intervention, in order to achieve that. So that for me, it's exactly what you're getting at, to say at what point do we empower the person? I mean, when Peter responds, she wants to see the microbiome, but she's not going to come back to you for an intervention. She wants to go ask the ancestor, grandmother spirit, in order to find out what to eat. But it's that tension for me. It's how do we move from that advancement of being able to see the microbiome, but also not just come up with medicalized interventions only, but also come up with interventions that can empower the person to be able to look after themselves. But it is an important point you're raising in terms of the power dynamic that is involved there, or the quick wins or the easy solutions versus the more challenging, perhaps sustainable solutions. I don't know. Who should do what?
Who should do what?
Yes.
Well,
You had like 5 things that need to be done.
Yeah, yeah. So of my 5 things, okay. So 2 of them had to do with research. 1 had to do with public communication. No, 1 had to, actually 3 of them had to do with innovation and research, and that involves academia and funders, okay? So the one that had to do with keep doing research, using different methods and having this thinking, systems thinking, and then innovative tools. So I think in those 3 areas, we're talking about researchers, academicians, and funders that should be thinking about it, okay? So then we have the other 2. 1 had to do with communications and then policy. So I think in the area of communication, we as academicians or researchers, we have a role on giving the information that we're terrible communicating. So I think we need to work with other agencies that have the possibility, like in Latin America, I think we have to work with PAHO, okay? And see, and with communicators with them and see how can we translate that type of information. Eventually governments should start working on that. And I think we have to involve the civil society also, okay? And I think more often in global health, we're involving also journalists. I think we have to involve journalists. They know how to take those messages, and we have to guide them so they don't make it too sensational, but the way we need it. And finally, policy, okay? So policy is the more difficult one, okay? Part of it, I think the communication will need to be different for health providers, for the people in general, for community, and for policymakers. And I think there is a role of WHO, academies like this one, PAHO, to try to start helping policymakers shaping what policies or how policies should change, okay? So I think we have to start from there, because I don't think this is going to come very easily from countries. So I think we need these global health entities to start giving the ideas of how policy should be changing. So those are my different levels.
Well, the easy answer is to say everybody. But it's also true that in some cases there will be prime movers and others would have to support. And that's where we have to identify the prime movers and say, okay, who can actually move it? And certainly in terms of research, it will be the academia and the funders. But the academia have to articulate the need so that the funders will change their behavior. Because right now they're entrenched into certain siloed streams. When it comes to actually bringing about changes in the health system, of course, the policymakers matter, but health system managers and planners and others do matter a lot. And that's why health professionals also need to be actively engaged, and patient groups also need to be actively engaged. But ultimately, it is the health system managers who will be the prime movers for the change, to make sure that the convergence is taking place in actually the service delivery level. When it comes to public communication, basically, you have left it to the media, Patricia. But the problem, of course, is that now we are dealing with a media which is also spewing out fake news. A huge amount of false science is also being propagated. And therefore, while certainly it is important that the media actually becomes an important medium, a channel, we ought to have the alert academia to correct false notions, and at the same time, civil society also rising up, partly to ensure that the false notions, whether it's vaccine refusal or whatever, is not disseminated widely, but also hold the media accountable. So I think in each of these, there are people who will have to be principally responsible, but others will have to play a supportive role.
Yeah, I'm not sure I have a good answer. I think I've sort of communicated myself out, but I mean, I'm sort of obsessed with this notion about communication. I just wanted to tie onto your concept of the Overton window, because I actually deal in the exact opposite world. I find myself trying to demand change and being only consulted with, well, that's not feasible, that's not practical, we're too poor, what can we do? That's the least initiative. And I think that what really has always bothered me over the past sort of 10 or 15 years is how the HIV movement, finally changed public health from thinking about, I'm only going to ask for $1 because I might get $1, to saying, I'm going to ask for what is just. And I'm going to demand and keep demanding until I get that, even if it means I only get $2 tomorrow or $3 tomorrow. So I think we'll have to start figuring out how it is that we do that in this regard. I think I just need to think a little bit more about it. But I would harp on this issue about communication and making sure all of us are working with communities. And this whole notion of civil society engagement is absolutely critical. I also find that one of the biggest challenges I think that I've encountered in Africa is really just the incredibly low expectations people have of what government provides to them and the health services. I mean, it's really fundamentally the root cause of why we have Ebola outbreaks, right? People don't demand that their health facilities be safe. They don't demand that governments provide them with good health services, so they don't go to health facilities after they get sick, or they go there and they get sick and they don't fix it. So I think as it relates to this, I think thinking about as it relates to the common denominator, which is high quality, nutritious, safe food that's going to, whether through the microbiome or whether just through standard thermogenesis, result in a healthy body. I think thinking of ways that we can educate ourselves, our fellow colleagues, and then, of course, civil society groups to demand better from their governments.
On that note, let's thank our panel with a round of applause. Thank you very much. We'll move on to the closing remarks. Thank you.